And now I would request Dr. Aniruddha Kulkarni sir to present on imaging in male infertility, scrotal Doppler and truss. I would request moderators Dr. Nagesh Nagapurkar sir, Dr. Ajay Vare sir, Dr. Sharad Joshi sir to come onto the dais.
Next 15-17 minutes we will briskly go through male infertility imaging. No disclosures financially, images belongs to my center. The images which has been taken from the web has been duly acknowledged, and sincere thanks to Dr. Panitkar sir, R.C. Joshi, Nusrat Farooqi, Atul Gadkari, Dr. Abhay Mazen for providing me clinical material for years together. These are the common factors which are looked at when we look at male infertility: pre-testicular component, testicular and post-testicular. For testicular component, more or less, scrotal ultrasound is the key. In case of post-testicular, where the apparatus of draining is under investigation, probably we do truss, and many instances probably for erectile dysfunction or penile plaques, we do penile ultrasound. In cases of an isolated right-sided varicocele, we always should extend our examination to retroperitoneum to look for any retroperitoneal masses, because for which probably ultrasound as well as cross-sectional imaging may be required. And whenever the ejaculatory duct obstruction is being considered as one of the cause for the male infertility and the ejaculate volume is low, always look for retrograde ejaculation as one of the cause, which can be studied by doing urine analysis in post-ejaculatory phase. The most significant cases where probably the investigations are asked are azoospermia, where there is a complete absence of sperm, low sperm count, oligospermia. In case of poor sperm mobility, asthenospermia, or abnormal sperm morphology for that matter. So when we say it's a non-obstructive azoospermia, we are looking at hypogonadotropic hypogonadism, for which probably different hormonal assays will be required. In case of hypergonadism, probably on some of occasions in terms of imaging as far as MR and other ultrasound modalities will definitely be of useful. Looking at the report per se, whenever we are considering primary testicular failure as the etiology, we know that the testicular level and testicular volume is low, in contrast to hypogonadism, where all the parameters including follicle stimulating hormone and luteinizing hormones will be low. So all such patients should be treated with associated reproduction. MR will be asked in cases where hypothalamo-gonadotropic axis is considered at fault, and MR in case of male infertility is a separate talk altogether. In case of obstructive azoospermia, when we are looking at it, the corrective measures could be in terms of vasostomy or vasoepidermal anastomosis, where probably the cause of obstruction needs to be relieved so that the proper transportation of the sperm will occur to desired area of interest. So ultrasound evaluation more or less consists of penoscrotal curve Doppler and transrectal ultrasound, where we do testicular assessment, paratesticular assessment, and transrectal ultrasound will look at seminal vesicles, ejaculatory duct, and vasa ampulla. A primary look at the penile shaft for presence or absence of large plaques involving the penile shaft is equally important. On many instances, we are asked for a penile erectile dysfunction study, where we want to assess whether it's a venous leak or a primary arterial cause for the erection deformity. In patients when there is a cryptorganism where the testes are present high up in the abdomen or within the inguinal course, then we need to look at the testis as far as localization is concerned, and that we can do through a technique what is called a tracking cord technique. And we need to identify the abnormal location of the testis for its normal appearance, which the testis is small and the ecotexture is normal or abnormal. On many instances it could be atrophic testis, or many instances it could be a completely non-demonstrable testis. And this is how we can go ahead. So we always track the cord in a cross-sectional fashion and go systematically up above from the upper part of the scrotum high up into the inguinal canal as well as along the posterior abdominal wall. And it's the easiest way of tracking the cord technique for identifying the testis in the inguinal canal or the posterior abdominal wall. At the same time, we need to differentiate the testis from inguinal nodes. On many occasions they may mimic to each other. Whenever we find that the testis at an abnormal location, we need to characterize the echo-characterization in terms of size and overall homogeneity of the texture, and we find that in contrast to the normal testis on the opposite side, it has got a smaller size and heterogeneous in appearance. On many instances you will find that the architectural distortion of the testis can be seen or equal component in cases of post-sepsis sequelae, that is post-epidermal orchitis. We will find areas of infarcts within the testicular component which are seen as a hypoechoic areas. There are certain patterns of testis which have been associated with subfertility, and one of the common topics for that is what is called the striated testis, where you will find that there could be a small amount of hydrocele associated with striated testis, and you can appreciate multiple hypoechoic areas which are like onion skin pill-like appearance within the testicular pattern, and these are nothing but striated testis. On many instances, you will find hyperechoic areas within the testicular component which are nothing but areas of lipomatosis, which is also associated with some degree of subfertility. Now, there have been studies which stated that subfertility could be associated with microlithiasis, where homogeneous component of the ecotexture of the testis can be identified, and starry testis will be seen where hyperechoic areas intermixed with hypoechoic areas of normal homogeneous appearance can be seen very well. To classify the obstructive azoospermia as a etiology, it could be epidermal cause, could be vas deferens cause, or could be ejaculatory duct cause. Again, it could be congenital in terms of malformation as a hypogenesis or complete absence, or it could be acquired because of any surgical intervention or post-traumatic or post-infective, and we will see some of the dogmatic cases. Now, in cases of congenital bilateral absence vas deferens, there is efferent ductal dilatation and head of epididymis will abruptly stop, and we will not be able to identify the body and tail of epididymis on the same side, and dilatation of retitestis along with speckled appearance will be seen characteristically within the testis as well as the epididymis. So we should always train ourselves in identifying what is called the speckled appearance, which is the characteristic feature of tubular ectasia, should be always seen at the retitestis as well as within the course of epididymis as from head to the tail in this region. On many instances, this can be associated with what is called the dancing megasperm, which is again usually sequelae to the tubular ectasia in that individual. So identifying tubular ectasia involving retitestis as well as epididymal head and body and tail could be one of the important key feature in assessing the male infertility. Now, in patients who presented with large epididymal head cyst or spermatoceles at the superior pole of the testis, always should look for posterior acoustic streaming, which is classical literature based sign for stating it to be a spermatocele. On transrectal ultrasound, abnormalities of ejaculatory duct apparatus can be documented very well. Level of obstruction for surgical planning can be seen. At the same time, on many instances, we can use it as a guided technique for draining the ejaculatory duct cyst, and it has almost replaced the vasography on many instances, but few of the plastic surgeons, they are still demand vasography on many instances. What is the size criteria for seminal vesicles? The normal is usually 25 millimeter, hypoplastic is in less than 16 millimeter or between 16 to 25. Severe hypoplasia or atrophy where it is less than 16 millimeter, on many instances it can be completely absent. In case of ductal obstruction, the seminal vesicle width has to be more than 15 millimeter. Ejaculatory duct, which is seen in the terminal course within the intraprostatic utricle, should be more than 2.3 millimeter, and usually they are associated with some amount of cyst or calcification within the same. The causes on transrectal ultrasound can be correctable and the non-correctable one. The correctable one basically where the obstructive process is involving the sperm transport mechanism. Now, this is how the transrectally normal ultrasound will look like. Here my objective will be to look at the terminal course of ejaculatory duct. At the same time, the seminal vesicles in terms of its characterization and the course of ejaculatory duct in terminal course should always be mentioned in our report. So seminal vesicles will be seen as a hypoechoic lobular structure on either side, which is classically described in the literature as a bow appearance or moustache appearance. And we should always look for presence or absence of a cystic areas within the seminal vesicle substance or within the utricle, which is within the course of ejaculatory duct, and we need to comment regarding presence or absence of such cyst. On many instances, single or multiple calculi can be noted within the seminal vesicles, or on many instances you can also see a calcification which is well walled off within the terminal course of the ejaculatory duct. Whenever we found that there is a midline cyst, it is usually this midline cyst which is responsible for obstruction in terminal course of ejaculatory duct, and if the cyst within the midline course is very huge or large, then we can put a small needle through a transrectal route. We can drain that entire area within the cystic region over there, and it can completely disappear altogether. So here we are not removing the cyst per se, but we are just draining the cyst so that the obstructive component of the cyst over the ejaculatory duct apparatus will be relieved. Now, seminal vesicles as well as ejaculatory duct obstruction in terms of its abnormality or hypogenesis also can be commented on MR. These images have been taken from Dr. Sharad Kondekar, and you can obviously see the larger sizes, the cyst present within the prostatic utricle. Coming to important thing, and most of the times we are blamed for labeling so many varicocele every now and then, grade 1 and grade 2. But literature has clearly stated that it has to be a clinically overt varicocele, which is not only in terms of say supratesticular in location as far as the reflux is concerned, but the reflux, the dilatation has to be independent of Valsalva maneuver during lying down position and extending that into a peritesticular component or intratesticular component, which is clinically overt one and which is responsible for subfertility. So let us take one or two examples of such classical varicoceles, and let us stop describing 2.2 millimeters of dilatation with increasing it to 2.6 millimeter and stating it to be only in the inguinal region and calling it as a higher grades of varicocele. So it's very important. Literature has mentioned it very clearly as far as the grading is concerned, and we can always keep that ready for us on our desktop, and looking at the quantitative measurement of the venous dilatation, the characterization of the wall, presence or absence of a testicular hypertrophy along with the presence of a testicular varicocele on that side, and then we call it as the clinically overt varicoceles. Now here in these serial loops you can appreciate that the venous dilatation of pamphiliform plexus is definitely significant where dilatation is more. At the same time, the reflux also is noted not only with Valsalva but also during normal respiratory phases. So it is our duty to assess, number one, what is the grade of reflux in terms of with Valsalva, without Valsalva in lying down position, and depending upon characterization of the wall of the pamphiliform vessels, number 2 dilatation, and number 3 reflux, and number 4 presence or absence of testicular hypertrophy should be labeled. Now here you can appreciate that there is a peritesticular enlarged pamphiliform vexus which is showing normally also great reflux within the paratesticular area of the scrotum. So these are classically higher grades of reflux where not only the supratesticular component but the testicular and paratesticular component are also increased. At the same time, during normal respiratory physicality also there is a reflux within the same. Abnormalities of seminal vesicle could be a congenital again and again acquired, as we have seen in the initial literature, but we are always looking for the seminal vesicle width and the course and dilatation of ejaculatory duct. The anomalies of vas difference also, even though they are rare occasion, definitely can be commented on transrectal ultrasound. Now here you can appreciate the right sided seminal vesicle is very nicely seen, but if I try to locate the left sided one, I am unable to locate the same, but at the same time I can see some amount of outpouching over here. Probably that's a rudimentary part of the seminal vesicle on the left side, which can be also traced to a little bit of more than 2.5 centimeter on the left side. So probably I am dealing with unilateral absence of seminal vesicle on the left side. Now look at this report. Here you can appreciate there is a complete azoospermia over there. There is absent fructose as well over there. So what am I looking at? I am suspecting congenital bilateral absence vas difference. I can demonstrate the epidermal head on both the sides, but I am unable to track the epidermal head along the posterolateral aspect and look for body and tail of epidermis in the testicular ultrasound. At the same time, on transrectal ultrasound, I am unable to demonstrate the terminal course of seminal vesicle ejaculatory duct on both the side, which really means that we are dealing with bilateral absence of the duct. Now let us take few of the case scenarios probably which comes, that is normal ejaculatory volume, the fructose is positive, the pH is normal, there is absence of sperm, But testicular biopsies, there is no spermatogenesis, then probably we are dealing with what is primary testicular failure. In case of low ejaculated volume, it's low pH, there is absence of fructose, and the fluid is very thin, then we are looking at some ductal obstruction over there. We should always and always look for presence or absence of inflammation or a calculous disease. In case of a normal volume ejaculate and there is a testicular abnormality or vasectomy has been done, always look for some amount of post-inflammatory ejaculator obstruction in those individuals. When the volume is low, that is less than 1 millimeter, patient should always be evaluated for distal ductal abnormalities including agenesis and hypoplasia or some amount of obstruction caused by fibrosis or calculus. Few of the cases we have seen earlier. Now in patients, when there is a normal ejaculative volume, the fructose is positive, there is a normal pH, but it's absent sperm. In those patients, probably testicular biopsies will say that it's a normal spermatogenesis. It's the cause is the obstruction to the proximal passage, testis and distal vas for that matter. Now this is one of the example. Here you can see obviously as compared to other testises what we have seen earlier, both the testis appears to be smaller in nature. The right testis appears to be more hypoechoic and homogeneous, but the left one appears to be heterogeneous in nature, and the report was a non-homogeneous ecotexture of smaller size testis without any ectasia features, that is no signs of obstruction at the rete testis, and on the semen analysis report it was no dead or live sperm which were detected in this patient. So probably we are dealing with some amount of primary testicular failure because of testicular region. So looking at the entire cases that we have seen up till now, a systematic and a logical approach and through evaluation is mandatory to distinguish patient from correctable defects and from the non-corrected defects. And definitely penoscrotal ultrasound, color Doppler and transrectal ultrasound will definitely help for the same. Thank you.
Thank you, sir, for very valuable presentation. Next, I would call upon Dr. Sandeep Bhati, sir, to give valuable presentation.
Thank you for giving me this opportunity. My topic is male infertility, scrotal Doppler and transrectal ultrasound. So male factor is present in almost 40 to 50% of patients with infertile couples. The infertility in male, it faces many management hurdles. Like men, they often do not seek evaluation. The female is extensively investigated, but the male factor is often underestimated or its investigations are postponed. Semen analysis, which is the basic investigation, which is not standardized, and various labs gives variable reports. Radiological investigation like scrotal Doppler, transrectal ultrasounds, which are complementary to clinical evaluation, but they are highly subjective and they are not standardized, and they are managed by different non-specialists as well as different pathies. Let me give this disclosure that this is not to defame any center or a particular sonologist. This is the classical examination example where the subjectivity comes into place. This is the scrotal Doppler done of a PR patient in May 2021, few days apart. One of the sonologists has given grade 4 varicocele while the other has given grade 1 varicocele. So there is a lot of subjective variation in the sonologist reports. Scrotal sonography is done to detect many infertility factors like varicocele, epididymitis, epididymal cysts, spermatocele, testicular tumors. The varicocele being the most common factor in primary infertility and which is the most common correctable reversible factor. It is present in almost 35% patients in primary infertility, while in 80% patients with secondary infertility, that is those who have fathered a child before. Varicocele is the dilatation of the pampiniform plexus. This is the clinical grading system. The subclinical varicocele, that is those detected by sonography but which are not clinically palpable, they have no clinical significance and those should not be treated. The scrotal Doppler for varicocele, it is indicated only when the patient has clinically palpable varicocele and when the surgery is being planned. Subclinical varicocele, as I have mentioned, that those which are detected only on the sonography and they are not detected on clinical examination, they have no significance. But scrotal Doppler can be done in patient where the clinical examination is supposed to be substandard, like in patient who are very obese, who are very anxious and cooperative patients, who have thick walled skin, or when the testis is very high that the cord examination is not possible properly, or when there is a varicocele recurrence after surgery. In that case, the cord palpation is not proper. In those cases, scrotal Doppler can be done. It can give you idea. On scrotal Doppler, one should mention about the testicular size and volume. As you know, almost 80% of the testicular volume is made from the germ cells and the seminiferous tubules. It is the functional unit of the testis, and whenever there is reduction in the germ cell or functional units, then there will be reduction in the testicular volume. In long-standing varicocele, this germ cell will come down and the testis volume will decrease. So you should mention about the discrepancy in the size of the testis on both the sides. During the examination, one should avoid the compression of the scrotum. It should be avoided because the testis is very sensitive to the compression and it influences the diameter measurement of the testis. Also, during the cord examination, one should not compress the cord structure because it reduces the vessel diameter and it will increase the flow during the cord examination. Three-dimensional measurement should be done given like length, weight and height. Normally, the ellipsoid formula is commonly used. But the Barry has done has a publication where he has mentioned that he has measured the testicular volume by all the three formulas, pre-orchidectomy and post-orchidectomy, and he said that the Lambert's formula is more specific, but the ellipsoid formula is more commonly used. Normally the testes, they are symmetrical bilaterally. While examining the scrotum, what should be the position of examination of the during the Doppler? Majority of the investigators, they have advocated that scrotal Doppler, it should be done in both the supine position as well as the standing position, because during the supine position the veins collapse and the varicocele grade cannot be assessed properly, and most accept a size threshold of 3 mm during the Valsalva maneuver in standing position as the diagnostic of the varicocele. This is the one publication by Mehdi Karami, who has told that the varicocele, it is to be assessed in upright position and with Valsalva maneuver. This is another article in Korean Journal of Urology, who have examined 113 patients, and they have concluded that the color Doppler should be done in the standing position, and they have also assessed the ratio, resting Valsalva ratio in standing position, which could be a diagnostic factor for the varicocele. Which vein should be assessed? There are multiple publications which suggest that the veins at the epididymal head should be assessed, or supratesticular or inguinal vein should be assessed. But the largest vein, which is present in the scrotum, that should be assessed, and irrespective of its position, and it should be measured when standing and during the Valsalva maneuver. The venous diameter is measured, even it is measured in this way, the 3 mm or more is considered diagnostic of varicocele, but it is not the constant, but you have to take multiple factors, that when venous diameter, then even if the venous diameter is less, like 2.8 mm, and there is presence of early reflux or reflux is there, then one should mention that varicocele is present. Reflux is the most important factor, because it will give you the prognostication of the surgical correction. It is the main predictive factor of a better seminal response after varicocele correction, that you can predict that this patient with high grade reflux, he is likely to recover from after the surgery, and the seminal parameters will improve after surgery. And this reflux, it can be missed when the patient is supine, so it should be evaluated in supine as well as in standing position and with the Valsalva maneuver. This is a publication in Journal of Urology by G. Legori, who has stated that it is the presence of the reflux, it is the strong preoperative color Doppler indicator that the postoperative there will be improvement in the seminal parameter after varicocele correction. What should be the duration of the venous reflux? Few have classified venous reflux as when it is less than 2 seconds, it is supposed to be mild. When it is more than 2 seconds, it is supposed to be severe. To say that it is a significant reflux, the venous reflux should be present at least for more than 2 seconds. Grading of varicocele, there are different grading, and there is no standardization of the grading system. There are various grading systems have been mentioned depending on the venous width measurement, venous reflux level, reflux duration, or velocity, venous regurgitation velocity, and difference in diameter at rest and valsalva. So there is no standardization of the grading of the varicocele, but one should, during the sonography report, one should give this table which should mention the diameters of the veins in a different position, in supine position, in rest and valsalva maneuver, during standing in rest and valsalva maneuver, and whether there is presence of reflux or absence of reflux. That should be mentioned on the sonography report. That will give the clear-cut idea to us. About the transrectal ultrasound, it is done to detect the distal genital tract abnormality, that is at the vessel ampulla, seminal vesicles and ejaculatory duct, which should be present in 5% of infertile male. The patient will have low volume ejaculate, azoospermia, negative fructose, the volume will be normal, and the hormonal analysis, that is FSH, LH and testosterone, that will be normal. In cases of congenital absence of unilateral or bilateral VAS, on transrectal ultrasound, the seminal vesicle will be hypoplastic or absent. This truss in these cases with the absence was difference, it is just complementary to the clinical diagnosis. The main diagnosis lies on the clinical examination, and even if the seminal vesicles are present, which may be which may happen in 3 to 4% of patient, even with the was difference absent, in those cases the management will not change. Management will be to do epididymal sperm aspiration or testicular sperm aspiration and go for the ICSI. Ejaculatory duct obstruction, the ejaculatory duct can be divided, it can be divided in 3 parts, that is extraprostatic ejaculatory duct, intraprostatic, and at the distal part, at the verumentanum. If the ejaculatory duct obstruction, it is diagnosed when the seminal vesicles are dilated more than 1.5 centimeter, ejaculatory duct are dilated more than 2.3 millimeter, and when there are cyst, calcification or stones along the duct. Sonologist can give a clear-cut idea of where the obstruction is on transrectal ultrasound, and which will help us in planning the surgical treatment or prognosticating the surgical treatment. Because when this dilatation lies in intraprostatic or at the distal part, then it can be corrected surgically, and when it is lies extraprostatic, it is difficult to approach from the intraureterally, and we may counsel the patient regarding the failure of the surgery in those subjects. So this is the one thing where the sonologist can help us in predicting the surgical outcome of the patients. Like in this case, it is at the distal part at the verumentanum, and transureterally it is resected, and this ejaculatory duct obstruction is relieved. So in conclusion, the radiological investigations are extremely important in evaluation of male infertility. The scrotal Doppler for varicocele, it should be done in supine as well as in standing position, and at rest and with Valsalva maneuver. Please mention about the testicular size, whether there is any discrepancy in the testicular volume or size on the both sides. You should measure the largest venous diameter. You should see the presence of reflux or not, or duration of the reflux. Truss for ejaculatory duct obstruction, it should mention whether the ejaculatory duct is dilated intraprostatically or extraprostatically. It will help us in planning the surgical management. Thank you.
Dr. Sandeep, very good presentation, and Dr. Kulkarni, presentation is very good. Now, in the past, there used to be a thought that whether you should go for Doppler or not, but today it is mandatory because we are living in the evidence-based medicine and subinguinal microsurgical techniques. This is number one. Number two is you have all mentioned that the Dopplers and different types of study and all, but I tell you, in secondary infertility, the operation of varicocele is necessary, or should be done even in subclinical cases also. We have a paper for secondary infertility and repair of varicocele. So what we decide to operate the varicocele is the semen parameters, and in secondary infertility, where the semen parameters are the stress 1 and a patient had a secondary infertility, even subclinical varicocele, which is shown on the ultrasound or Doppler study, you should go for the surgery of a microsurgical technique, and if it is demonstrated grade 1, grade 2, you can go for the either other method also. These are the two most important things while we are looking after. And another most important thing is that follow-up of the patient. When we operate the varicocele follow-up, we generally do not do the follow-up by doing the Doppler study. If pre-op Doppler you have did it, and in post-operative study, we do not do the Doppler study again. We follow it with the semen analysis. What is your experience for the follow-up of the patient for the Doppler study?
After
Follow-up surgery, post-surgery follow-up with the Doppler study.
post-surgical, I mean.
Varicocele operation, sorry. Varicocelectomy, post-surgical, follow-up with the Doppler ultrasound.
I mean, I've never got a requisition for the same.
That's it. Because we never ask patient ever to go for and do the Doppler. If somebody has operated and he comes to you for the second opinion, we may ask. Because we always do the follow-up of the patient with the semen analysis. And I had a paper in secondary infertility that there is spontaneous pregnancy 20% and improvement in the semen parameters up to 60 to 70%. Because 80% of the cause in secondary infertility are because of varicocele. So even if varicocele is subclinical grade 1 grade, you should go and do the operation. That is what I am to say. And follow up, because in the past they don't do the Doppler study also. In 20 years back, there used to be discussion whether we should go for the ultrasound Doppler study. It is expensive in the past. But now in the evidence-based medicine, you should do it. And the mentioning of the testicular volume is also very important. Because as we have seen in the prostate, all the 3 dimension plus volume of the test is also very important. Another one point I want to ask Dr. Kulkarni, have you seen any case of intratesticular varicocele?
Yes, I have seen.
Yes, because that is a very classical one, because if you want to, patient has got arcalgia, and clinically there is a main varicocele or may not be varicocele, but if the demonstrated intratesticular varicocele, counseling is the most important thing to the patient, because what happen, we do the counseling in fertility patient who had arcalgia and varicocele. But even if you operate for the varicocele, arcalgia will not go. Patient will come to you daily that I don't have any relief. In that case, if you do the proper ultrasound, you can diagnose it. You can throw any more light on this.
No. See, in terms of treatment, I don't have any experience for that. But whatever you have said in terms of subclinical levels of varicocele.
In secondary infertility. In secondary, I am talking in secondary.
In secondary infertility.
Yeah, not primary.
Okay. So I mean, in terms of radiologists reporting the varicoceles, we need to look for primary infertility or secondary.
Yes.
In case of secondary infertility,
yes,
even though the venous dimensions, grade of reflux, standing and supine position are clinically overt one.
Yes.
However, insignificant or a significant varicoceles that we document,
yes,
is clinically important as far as the
if any other cause,
yes,
and semen parameters are stress one, we should go for surgery. Sandeep, you want to add anything?
I agree with.
Post surgery, there will be fullness when the varicocele is very large, and when you do the varicocele surgery in your first question, there will be fullness which will be present for 3 to 4 months after surgery.
Yes, that's why.
And when you do scrotal Doppler, they will.
Yes, because and what happens when you do the follow-up ultrasound, then there is definitely going to be seen the reflux and all these things and dilated of the vein. If you want to really do it after 1 year. Whether your surgery has been failure or not, you can see after 1 year. 3 consecutive 2 months semen analysis sample. If they doesn't turn out to be the improvement or they are declined one, even if after 2.25 months or even 8 months, then you can go for that. You can declare that after 1 year that my surgery is not succeed, and you can opt for another procedure.
One thing I can say that. The scrotal Doppler should be done in standing position, because in our clinical practice, most of the Doppler reports come in supine position, and it loses its clinical significance.
In the other hand, I will say that when patient comes to the radiologist, he should ask patient to walk and then do the standing position Doppler and see for Valsalva. Because most of the time,
Sir.
Sorry.
Yes.
Most of the patients don't come with semen analysis.
Yes. Because whenever I refer to the patient, I write complete history and all my findings, and then I send.
Depending upon the scrotal semen analysis report, whether you can direct your study for doing only a ultrasound
sir.
or a transrectal ultrasound.
We are having-
If there is a complete azoospermia, then it should always be followed by transrectal.
Thank you so much. We are short of time.
Nagapurkar sir,
Yes,
I agree with you, but this that is not rule. Okay, very good. I mean,
In secondary infertility,
agree.
not the rule, but it depend on semen parameters.
Should not be done.
Exactly. There are the incidence of improvement in the semen parameter, patency rate, as well as the pregnancy rate. The improvement is very less, but it is there, and literature is also there. I agree with you.
See, I agree with Dr. Mishri Kotkar. Many urologists are guilty of writing a suboptimal requisition. They don't ask correct questions. What I expect or what I want, and then crib कि radiologist ने तो ये दिया ही नहीं, वो दिया नहीं. So my suggestion to my colleagues
Yes.
also is
Yes.
ask the correct question.
Yes.
What I want.
Yes.
And second,
And if your radiology colleague doesn't give it, then
Talk to them and
No, sir,
write the
no,
history
no.
properly.
Second-
Because while you say the requisition, write it down
No,
the
no,
history.
second-
That is
sec-
mandatory.
Secondly, don't accept the suboptimal report. I think.
Yes.
See, one of the biggest study which has been conducted in NHS UK in 2010 to 14 was that the expertise of imaging specialties entirely depends upon question posed by the clinicians. I mean, if you are happy with the post-void residue of 40, 60, 80 prostatic volume of anything, unless and until you question me my report, I am not going to change at all, because I am gaining money out of every requisition that comes to
Yes,
me.
yes.
So don't accept the suboptimal report. That's the first thing. As he has rightly stated that the requisition has to be complete, but there has to be what you can say, first and foremost, protocol in defining. See, no scrotal ultrasound is complete without defining the renal parenchyma. For that matter, everything you need to say that there is no obstructive uropathy in the kidneys if the testicular ultrasound is asked for. Similarly, in case of pediatric age group, I mean, it's not a part of today's event, but still, no abdominal ultrasound in case of pediatric age group is complete without testicular examination. And same is the vice versa. When you ask for testicular ultrasound of any etiology for that matter, unless and until you give some kind of information about the proximal system of kidney, that the report is not complete at all. Same is, I mean, it's inguinal scrotal ultrasound. It's never a scrotal ultrasound per se isolated. So you need to give information for presence or absence of any hernias for that matter in the inguinal region, which could be one of the factor which is responsible for, number one, venous obstruction, number two, on many instances it could be a formidable cause for testicular torsion, because I have seen 2 cases where the irreducible inguinal hernia was the cause of the testicular torsion on that occasion. So we need to look into this as a specific entity for that matter, that suboptimal ultrasound should not be accepted. You should always send back the patient if the prostatic volume is not given, intravesical medical length is not given, if its volume is not given. So
Yes,
you
I
can
agreed
send
with
it
you.
back to me on
That
two
there
approaches.
should, that means
So
there
that's
should be
very important.
communication. Number one. Number two, radiologist should spend time to the patient. Because I've seen the radiologist, particularly in the institution, because he had never seen the face of patient, dark patient came out, he gone out, report has thrown, and evening the patient collect the report. So interaction to the patient by the radiologist and surgeon, of course, both, and interaction of the surgeon or urologist and radiologist is mandatory.
Thank
So
you.
that we can come out.
Thank you both
so
the
much.
speakers and all the chairperson for a wonderful
Thank you, very nice
discussion.
presentation, very nice. very
Now
good.
there will be